Thank you, Mr. Chairman. Thank you, GIS, for the kind invitation. It's a real pleasure to be here. I'm Shana Tehrani. Sudhir Rathore is my lifelong mentor. So it is said that LIMA lives forever. Now we can see over the next few minutes, is it a myth or is it truth? Our patient was a 58-year-old gentleman who was directly admitted to our cath lab as part of primary PCI call after developing sudden onset chest discomfort associated with anterior ST segment elevation on ECG and complicated by cardiogenic shock. He was a smoker and hypertensive, and 4 weeks prior to this event, he had undergone coronary artery bypass grafting surgery with the LIMA graft to the LAD and vein grafts to the RCA and to the circumflex. Remotely, he had PCI to the RCA and to the circumflex. Diagnostic coronary angiography demonstrated severe proximal LAD stenosis. There is no flow distally in the LAD. And you can see extravasation of the contrast media into the pericardium. At this stage, we were suspicious that there might be some dehiscence or avulsion of the LIMA graft. LIMA angiography showed a sluggish flow, and there is no flow on the distal segment, mid to distal segment of the LIMA graft with extravasation of the contrast visible, and we were convinced there is LIMA avulsion or dehiscence of the LIMA graft at this stage. Soon after diagnostic coronary angiography, patient developed PEA arrest. He received 1 cycle of CPR, got intubated and ventilated. Echo showed a large pericardial effusion. About 700 mils of this was aspirated. An intra-aortic balloon pump was inserted. We didn't have cardiac surgery on site, and also patient condition was in critical situation. Therefore, we proceeded to emergency PCI to the LAD, cyan blue wire, lesion preparation with 2.5 millimeter semi-compliant balloon, and a 2.5 by 20 millimeter papyrus covered stent was deployed at the insertion site. At this stage, there is no further contrast media extravasation into the pericardium, and patient status actually was getting better. ST segment was resolving. We rechecked the LIMA graft, and there is still extravasation of the contrast into the pericardium. Therefore, LIMA was coiled by 4 tornado coils. Coil embolization of the LIMA was performed. Patient was stable, but echocardiogram showed that there is residual clot in the pericardium, which was very difficult to drain actually. Therefore, he was emergently transferred to the local cardiac surgery unit, underwent redo sternotomy and open drainage of the clot in the pericardium. He made a very good recovery. He was sent home a few days later from surgical center. He was reviewed in the outpatient clinic in 3 months' time and did not have any neurological deficit. About 5 months later, we did just a control angiography, and we realized that the covered stent was occluded, which is not an unusual finding. And this time, he underwent PCI to mid and proximal LAD back to the short left main with optimization of the circumflex. So, avulsion of the LIMA graft is very rare, but quite a catastrophic complication post surgical revascularization of the coronary artery disease. Until this case, only 7 reports in the literature were published. 5 of them were post-mid-cab and only 2 post-conventional cabbage. The exact mechanism and reason for this is not entirely understood, but it's widely accepted by the cardiac surgeons that perhaps an inadequate length of the graft and sudden shear forces on a vulnerable conduit is the main reason. Interaction of the graft with the edge of the pericardium, adhesion of the graft to the surrounding structures, CPR, hyperventilation, cough and sneeze, blunt trauma, and weight lifting, they all have been reported. Actually, our patient was a COPD heavy smoker patient who was straining with constipation in the bathroom when he developed sudden chest pain. In all previous reports of this condition, LIMA avulsion occurred a few hours post-procedure, mainly when the patients were in the ITU or were in the recovery. Latest occurrence that has been reported is 18 days post-mid-cap, and all of these cases were treated surgically. This is the first case that has happened 4 weeks post-conventional CABG and was treated very uniquely by percutaneous management. Meticulous surgical technique is crucially important, specifically adequate condyle length in COPD patients. It enables adaptation with the chest wall movements and lung and diaphragm excursion. When patients get extubated in the ITU, specifically in COPD patients, because of the sudden expansion of the lung, this can happen. LIMA avulsion should be suspected in anterior MI presentation on patients who have had bypass surgery in the past. A prompt percutaneous treatment can be life-saving, like what it happened to our patient. Thank you.
Excellent. Thank you very much. Panelists, your experience?